So our next speaker is David Elton. Dr. Elton is Senior Vice President of Clinical Programs at Optum, the business unit within United Health Group. So welcome, David.
So good morning. Thanks so much for the invitation, primarily to learn from all of you in the next couple days. And my purpose this morning is to share some data from the perspective of the payer to kind of get grounded in some context. And I'm going to resist the temptation to talk about all the good things we're doing with these data, but let's just dive right into the data. So sort of my objective this morning, total healthcare expenditures, and look at these non-pharmacological therapies. Really then drill into pain, and finally look at non-RX services for pain. An important caveat, right? So just like RCTs have limitations, claims-based data have a number of limitations that are important to sort of be aware of, right? So the consumers pay out of pocket, we know, for these therapies in particular, acupuncture, chiropractic services, massage. Even if covered, there's a fair amount of out-of-pocket expenditure that we can't see, right? We're blind to that in terms of the claims data. Non-covered services, yoga, virtual reality, mindfulness. As non-covered services, they're not represented in the data. We know that these are important therapies. We have a number of pilots going on, but we can't see what we can't see in the claims data. Incorrect coding. We're at the whim of millions of providers' coding practices, and so that introduces artifacts for sure. We're notorious for benefit designs, prior authorization, network strategies, all introduce distortions into the data, carved out benefits. The nature of capitation means some of these data are not always available to us. And a fascinating reality about prescription data is it's not associated with the diagnosis. How do we put that into the total story? So a number of caveats to the data, but nonetheless, let's dive in. So as was mentioned, United Healthcare, Optum, this is just a high-level summary, 2017 book of business, commercial, Medicare, Medicaid, enrollees, about 22 million roll-up. We're probably north of that, but gives you a sense of scale. And then high-level spending, outpatient, physician, inpatient, RX, mental health in the billions, so $138 billion of dollars to work with, broken out by these different settings, is the distribution. I think for today, the topics of interest when we get into pain, spending on imaging, spending on injection therapy, and then down below, spending on the common Stephen, okay, Dave, just for...
Feel more better now?
Yeah, I do. Yeah, I'm liberated now. I can really go at it. But so in these three channels, spending on these non-pharmacological therapies focused on pain, active procedures, the manual therapy, massage therapy, chiropractic manipulative therapy, acupuncture, passive modality care, and then osteopathic manipulation. As a percent of medical expense, in the commercial book, it rolls up to 2.5%. Is that too little? Is it too much? Can they be better deployed? If we invest here, do we save total? We'll talk about that tomorrow. But in aggregate, for us, across all three channels, about $3.4 billion in non-pharmacological therapies. And frankly, we think that's too low, so that's my only editorial comment for today. But so a fair amount of spending on these therapies is going on. And of interest, I think acupuncture, just preparing, was the biggest sort of aha for me. On our commercial book, about $136 million in acupuncture spending, which we have pretty uniform coverage for acupuncture, which we'll see is important as we roll forward here. Highlighted in red, though, as we move from the commercial book to Medicare to Medicaid, what we see is coverage for particularly chiropractic manipulative therapy and acupuncture tends to drop. As we move into Medicare, it becomes more constrained. And as we get into the Medicaid programs, I think we have 5 states that have acupuncture coverage and 10 or 11 that have chiropractic coverage, and often the coverage is pretty constrained when it does exist. So as we move into these more public sector books, as we call it, the coverage for these therapies becomes more constrained, which is an important public policy focus of ours, given the value of these therapies in the treatment of pain. So let's dive deeper into pain, so the context for today. And for this, we're going to focus on our commercial book of business just to get grounded in role of opiate and non-pharmacological therapies. And for this now, we've cut over to what we call, it's a symmetry episode treatment group or technology, which takes the claims data, creates episodes of care, This is a technology that does allow us to put together the total story and understand pharmacological spending by diagnostic condition. And we'll go through 3 slides to look at distribution of episodes, distribution of dollars, and then distribution of MMEs, so morphine milligram equivalents put into the system for the treatment of these conditions. On the left, a high-level cut at non-musculoskeletal episodes, what we call other musculoskeletal episodes, and then cancer. Blue is non-surgical episodes, orange are surgical episodes. And then on the right, it's the more detailed look at the specific episode type. And so you can see by an episode count basis or distribution, routine examinations and immunizations are the number one volume of episodes, followed by infectious disease, dermatology, metabolic or diabetes, and so forth, mental health, cardiovascular. And you can see where the story is going to go here is spine represents 4.5% of our total episode volume. If we then flip over to cost, so how do the dollars shake out by these same groupings? And now you can see the orange begins to light up a bit more, so surgical episodes become more prominent. But non-musculoskeletal's top category of cost, musculoskeletal complaints are about 16% of total cost, cancer, other. The conditions flip materially now on the right. So cancer now is in the top category of spend. Cardiovascular, diabetes, GI, mental health, nervous system. Spine is now up to 6% of total cost, about 50-50 non-surgical and surgical. And this is sort of the setup for the day for me is when we look at volume of morphine milligram equivalents put into the system by diagnosis. Musculoskeletal complaints are 74% of MMEs. But more importantly, when we look to the right, back pain now jumps off the chart. 52% of MMEs put into the system are for back pain, and the vast majority of that are for non-surgical back pain. So routine back pain is about 43-44% of MMEs put into the system. So it's pretty startling when we follow the prescription trail to get focused on which painful condition are we focused on. And certainly all the pain conditions are of interest, but back pain in particular has been an area of intense focus of ours over the last couple of years, for sure, if not dating back 5-10 years. So where are we spending money on spine-related disorders? So for this, we're looking at AHRQ categories 205, 211, or 212, which generally are the back pain AHRQ categories where dollars roll up. And for this, back to the data limitation caveat, when you push down to a line item detail and try and identify pharmacy data tied to a specific diagnosis, the data gets a little unreliable. And so for this, footnote, asterisk, took pharmacy data out, just because it's really challenging to nail attributing pharma to a specific diagnostic category. That said, best estimates are it's probably up in the 400 to 500 to 600 million range, so it's going to dilute these data a little bit. But let's look at spending for back pain. Surgery, number one, imaging, office visits, neuro, injection therapy, top 2 or 3 low-value services in all of healthcare. It's imaging and injection therapy for spine-related disorders, so they're near the top of the list. And you can see how that tails off. Of interest for the session, I think, today and tomorrow for these non-pharmacological therapies spending on back pain, chiropractic manipulative therapy, $280 million off a total of $3.8 billion. Active procedures, manual therapy, massage, acu, passive modalities, and osteopathic. So it's interesting that the distribution of dollars actually aligns pretty well with the ACP guidelines. So the use of the non-pharmacological therapies and where the spending is happening is actually not that far off from what the guidelines would suggest as first-line therapies. As 20% of total spine spending, is that enough? Is it not enough? We'll unpack that a little bit more tomorrow. But we think there's a case to be made that making more investment in these therapies spins off a number of total episode benefits. Reduce surgical rate, less imaging, less cost, less opiates. And so today we're sitting at about 20% of spine spending is around these non-pharma therapies. And recall on the total book of business, it's about 2.5%. So these therapies are very concentrated in the treatment of spine. This is an eye chart, but that's the point. And so if we follow these same non-pharmacological therapies, acu, chiromanipulation, osteopathic, and the active procedures, manual therapy, the total dollars above, so that's the same 1.8, 1.9 billion on the commercial book. And then on the left, the vertical axis, descending order, is where are we seeing these therapies used and how much are we spending on these therapies? And spine is at the top, musculoskeletal is at the top, but these therapies are used, they're covered and reimbursed for a wide range of conditions, which we think is a good thing. So we like to see that play out in the commercial book. Of interest to me, what jumped out, the one bit of an outlier here was headache and how prominent acupuncture therapy is in the management of headache. Preparing for today, I just wasn't aware that would sort of jump out, and it's interesting and good to see and more to learn there, I think. So 2 final thoughts, and Steve, I'm still on green, so maybe I can slow down here, but or give you some more time back. But so the last, we've been really focused on back pain and some really good work happening, and as an illustration of sort of the better together, none of us have all the answers, but collectively we get close. For the last couple of years, United Healthcare, Optum, American Physical Therapy Association, and Rob and his colleagues at Boston University have been doing a deep dive at Optum Labs, which is a pretty unique environment to do some good work. And we looked at new onset back pain and the role of non-pharmacological therapies on new onset back pain, role in this concept of first provider seen, look at timing, look at impact on opiate use and exposure. And the reference here is new onset back pain, early and long-term opiate exposure when your entry point is a PCP. That's the reference line. And then to the left would be less opiate exposure. To the right would be more opiate exposure by entry point. And what we find is when the first point of contact for new onset back pain is physical therapist, chiropractor, or acupuncturist, the odds of early and long-term exposure to opiates is reduced materially. And one of the top cost drivers, overwhelmingly the top reason for an opiate script, when we look at these data on the 90 days before an OUD diagnosis, what is prominent in patients care seeking before an opiate use disorder diagnosis? It's back pain. And so here we have 3 therapies that the guidelines suggest are important first-line therapies, and in the data when we see that first-line therapy are chiro, PT, acu, it's highly protective of early or long-term opiate exposure. So again, then the question becomes, how often are these used first? How can we make it easier to do this? And we'll unpack that tomorrow. We don't have the time today. But really important work. It's really been a process of discovery with our colleagues that we've been working with this on, and look forward to sharing this with the industry when we get this thing published. And the final thought, man, I'm going to give you some time back. I thought I was going to be pressed. But the final thought is, this is a complex topic. Coverage does not translate into use. And so what we're looking at here, non-surgical back pain, commercially insured, manipulation and opiate use based on first provider seen. This is 27,000 individual providers who are the first provider contacted for at least 25 episodes of non-surgical back pain. And then for those episodes, starting with these individual providers, what was the rate at which opiates were involved or manipulation was provided? It's the Wild West out there. When we look at a patient experience seeking treatment for routine back pain, this is based on not only the specialty of the first provider, but the individual first provider you happen, either by referral or looking up a network directory or talking to your friend, that you happen to go see. And so it is highly variable. And while the guidelines suggest manipulation has an important role to play, the reality is you're only receiving manipulation if you start with a chiropractor. If you start with any of these other, you're just not receiving manipulative therapy. And roll this out for acupuncture, for active therapy, for manual therapy, massage. Practice is so highly variable out there today, and that's where I'm really looking forward to the next couple of days to figure out how do we collectively help make this look a little bit more aligned with the guidelines and, payer, provider, from all of our vantage points. How do we reduce this really unacceptable level of variation in care delivery for top reason for an opiate script, top cost driver in healthcare. And so I really look forward to the next couple days, and thanks for the invite. Appreciate it.